we are implementing health service delivery, I think in our respective countries. By definition, going to, I think the last question, we're talking about going to case management. But what is the expected outcome? I think it's quality of care amongst the population that are at that level of care. And it is in that context that the programs, especially like for Malawi, where we have used our lessons that have been learned over the period of implementation to look at what are the best approaches we want to engage and provide services in areas where access to health facilities is difficult. We have therefore been able to discourage the use of volunteerism in our system because our public health system is free of charge, and therefore it does not make sense to ask people to be paid for services, yet they are poor. Yet those that are living in urban settings have the ability to pay or indeed access free public health services. We therefore say, because this is a health service, we need to identify individuals and people that are working within the Ministry of Health structure that will be able to provide services, for the poorest of the poor in respective catchment areas, so that issues of equity are also addressed at that level. So, by definition, I think that has to be contextualized, by different countries, and how we mentioned that we are defining these different ways, including living goods, but possibly after the symposium, people will be able to understand and be able to appreciate what are the things that we're supposed to do. iCCM is a good strategy, promising, and long as it is implemented very well. What is different, I think, for countries is not the three conditions are being implemented. You have challenges in other countries where they cannot allow antibiotics to be used by respective country problems. That is dependent on also how the country have done their assessment on the gap analysis and on the needs of those people. For us, most children have been dying at home without care, so we say this is the decision. A medical doctor, a specialist, is not supposed to be sitting in a clinic to assess simple fever. They have to deal with real situations and challenges. And we leave the few to the basics to the community health awareness. Sustainability, the way we have introduced our program in the country, is that you will see that we have discouraged volunteerism because it is difficult to manage and control and make decisions with people that are free and able to do anything. Our investment for our program in the country is that ideally, when we use the HSAs that are included and are part of the civil service, these people are responsive to the policies and strategies of the ministry, such that if they don't do things right, it is the Ministry of Health that is responsible, because one, they are misguiding them, or two, they are not giving the system support that they are required to get. We therefore have wanted to say, by establishing this type of strategy within an existing structure, the Ministry of Health, we have allowed to create the lowest point of care, and the lowest point being the health surveillance system. And it is in that understanding that everything that happens, including if we have a non-functioning health system in Malawi, it will affect everyone. If there are no medicines at community level, there should also not be medicines at health center level, and indeed at national level, because it is one system that is linked and it has to support and complement one another at every level. We have tried to make sure that the implementation in the country, in Malawi, is that coordination and leadership is provided by the Ministry of Health. We know and we appreciate the support that we get from different partners. These have lifespans. they will come and go. But the Ministry of Health, for its citizens, it will always be there. So what we have said is the partners' support should be seen to complement what the Ministry of Health mission and vision is expected to achieve. And therefore, what we do is there is no partner in Malawi who does implementation or support of iCCM without the knowledge of the Ministry of Health. And that has been the best, and all of the partners in the country, including the project officers that are assigned to do implementation of community case management, are part and parcel of the technical way on the CCM or the MCI in the country. And they plan, sit together, and share what is supposed to be done in this particular issues. And the implementation itself at operational level is entrusted in the hands of the district health management teams, who are basically the implementers of the interventions at district level. Issues of highlights that were mentioned about mapping and residences, residents of our CHWs. We somehow have issues that have to be tackled district based. They do not necessarily require national interventions. Issues of a female CHW who has been just or requires to be married, for example. We want particularly in our setting move to join the husband. And if the husband is out of that catchment area, it means this person will automatically want to move. And then may be closer, but with the husband, but then saving from a distance. That's one issue. Secondly, is the issue of housing. We're talking about hard-to-reach areas. Hard-to-reach areas have no appropriate structure for people that are regarded as civil servants. Glass touched, no window houses, whatever, the same way communities live, I think, in most parts of Africa. So that's one of the issues that we are sitting down and discussing with the district councils, who we call district commissioners, mobilize communities to construct structures so that our HSS should be resident there. Because our policy in government is no civil servant is supposed to be providing housing. Thank you for now. We can discuss later.
Address to you the first on community involvement and MOH leadership, ownership. I will address them separately because I do think that they're different things. In terms of Ministry of Health ownership, in South Sudan, the MOH's role in the iCCM program is really to create the policies, to oversee the implementation of various partners, and to make sure that there's consensus and standardization. Given the very young age of the country and the Ministry of Health, they have purposefully delegated the direct implementation to partners in the short term, in hopes of building capacities of county health departments and health facilities, and in order to fill the gaps that are caused by a very young network of health facilities. But that said, there is quite a bit of integration between the iCCM program implemented by partners and the public health facility network. For example, health facilities are used to stock drugs that are then picked up by the CBDs and CBD supervisors. There's a monthly meeting at the health facility to review the records of what was done in the iCCM program, and all trainings are done together. Eventually, the goal is absolutely to hand over the program entirely to the Ministry of Health, the local health facilities, and the county health department, but we're really only at the beginning of that transition now. In terms of the community involvement, the community is highly involved in the South Sudan program. They're the ones that select the CBDs in their villages based on criteria that the Ministry of Health sets. Community leaders, not even health providers, are invited to the trainings to see what services they can expect from their CBDs and their periodic sensitization meetings. So I think that's a really good point to bring up that all of us should be conscious about to try to improve. As for the question from SAVE, on the role that dismissed CBDs can play, given that they've been trained, that's a really good point, and thank you for raising it. I would say, firstly, that the dismissal is sometimes seen as an opportunity to improve the quality of the program. So some of those that are dismissed are not recommendable to other networks. So in that case, it's a good opportunity to improve quality. When they are, which certainly is the case, we do try to link them up with other networks that are blossoming. I know, for example, there was a network of reproductive health outreach workers that was being created at around the same time that we were dismissing CBDs, and so we linked them up, and they were grateful for that. But we ourselves don't have the mandate or the scope in this program to fund and train outreach workers that aren't CBDs specifically. As for tensions that can arise in the community when CBDs are dismissed, I was worried about that. We were all worried about that, and it went surprisingly well. I think that has to do with sort of the relationship that's built with the community from the beginning. And we made sure to have very detailed talking points as to why this process was being undertaken and how it was good for the PIAM and the county as a whole. We made sure to issue certificates to the dismissed CBDs. We had a little ceremony of appreciation with the community, and were able to give them recommendations for the high performers. So overall, tensions were sort of squashed.
Sorry, a bit of correction. I think the last.
Do communities pay for drugs, and how do we reach the poorest of the poor? This is probably the question that we get most commonly from the community health community, so it makes sense. Thank you for raising it and giving me an opportunity to talk to it. So yes, the customers of our CHPs do pay for the iCCM drugs. A couple reasons for that, and I want to kind of explain how it fits into the larger ecosystem. So in the communities where our CHPs are operating, a lot of customers, majority of customers we believe, can pay for the iCCM drugs, they just don't have access to them. And so our philosophy is that we maximize coverage, not necessarily equity of our program. As a private sector organization, our goal is to treat and give access to as many customers as possible for the lowest cost possible. And the idea is that that frees up the money from the public sector because they don't have to pay for costly ways of reaching the customers that have the ability to pay. That frees up public sector dollars so that they can spend more money reaching the poorest of the poor. So that's sort of our general philosophy, but a couple of caveats on that. So the drugs that our CHPs sell in the community, they sell at very low cost, and we are 100% certain that they're not counterfeit because they get them through us. So when you compare to the local pharmacies where a lot of people would be buying the drugs otherwise, they are lower cost, and we can ensure their quality. And actually, the midline results from our randomized controlled study showed that in the pharmacies surrounding the areas where our CHPs worked, in the control areas compared to the treatment areas, those pharmacies actually lowered their prices of iCCM drugs, and the rate of counterfeit drugs was lower in those pharmacies. And so that shows that we are having a bit of an impact on the ecosystem as well as through the drugs that we give out ourselves. The other point is that these two systems don't have to operate completely separately. So in Uganda, about a third of our CHPs are also part of the Ugandan government community health worker network. And so they get free drugs from the government, and they give out those free drugs to their customers. And the living goods business is a way for them to generate income through selling the Costos, the solar lanterns, the water filters, and the consumer goods at the same time that they're giving out these free treatments. And so it's a way to ensure that the government community health workers are motivated. They also get additional free training and support from us. And so your question sort of gets to the role of what is the role of the private sector, what is the role of the public sector, and how can those two things work together. And so we, after sort of testing out our model, want to now work with partners so that we can integrate it better with sort of government and public sector, community health worker models. I'm talking too much. Okay. Very quickly, over treatment. So our CHPs, in addition to selling the treatments for malaria, diarrhea, and pneumonia, pneumonia, they also sell over-the-counter drugs. And so for pneumonia, for example, if a patient has the indrawn chest and rapid breathing, they're told to give the amoxicillin. If they don't, then they have cough off. And so cough off is cough medicine. And then similarly for malaria, if the patient doesn't have malaria, then they're told to give Panadol or something else that reduces fever. And so they get a similar margin for selling the product that's actually a treatment versus the over-the-counter drug. So there isn't really a strong incentive for the CHPs to over-treat. And in addition, the treatments are just not where they make most of their money. They make most of their money on the other products that they sell, and so they have a strong incentive to have happy customers in their market so that they can continue to sell them other products.
Thanks everyone. I think we have to move on to the next session, but we really appreciate all of your participation and thank you again to all of our
A throat shown in green. Oh yeah, there you are. So, this slide shows that in most of these countries, 5 out of 6 of them, most of the volumes of the antimalarials are going through the private sector, as you can see. In Nigeria, for example, almost 9 times, the volume is almost 9 times greater in the private sector than the public sector. DRC, it's about 3 times. Madagascar, about 2.5 times. Uganda, a little bit more than half go through the private sector. But Zambia is the exception here, where most of the antimalarials are going through the public sector. Can I just close this door because it's pulling me off a bit, excuse me. Not going, honest. Thank you. Okay. So, what is actually being sold in the private sector? So this slide is showing all the different types of antimalarials. And so the good stuff, the best possible stuff, is the quality assured ACTs, those ACTs that have been pre-qualified by the WHO, and that's the light yellow. Non-quality assured is the sort of orangey brown colour. Non-artemisinin therapy, which is basically, chloroquine, quinine, and SP is the blue. And the non-oral artemisinin therapy, there's not much of that, but that's in that sort of pinky colour. And then the oral artemisinin monotherapy, the really bad stuff that's been banned in most countries, is in red. So as you can see, still, the majority of stuff that's being sold in the private sector is the blue, is the chloroquine, the quinine, and the SP. In fact, we've got the breakdown of that in the various countries. So you can see chloroquine, SP, and even quinine in DRC take up a larger part of the market share. So looking at households then, in this slide,